By Penn State Health.
Good evening, I'm Deborah Pinkerton. Epilepsy affects children and adults of all ages. Tonight you'll learn about the diagnosis and treatment of epilepsy from Penn State Health doctors. And you'll meet patients who are back to doing the things they love after successful treatment and surgical interventions. Epilepsy is the fourth most common neurological disease. Each year, about 150,000 Americans are diagnosed with it, and epilepsy can affect people in very different ways. So how is one diagnosed with epilepsy? How do doctors treat it? And what are the outcomes after treatment? We'll answer those questions for you tonight, and viewers have questions too. Denise McCracken is standing by with more. Hi, Denise.
Hi, Deborah. Yes, viewers have sent in questions, and tonight Dr. Bobbin Shaw will answer those questions about epilepsy. And if you have questions, you can join the live web chat right now. Go to abc27.com/brainstorm, and we'll be back later in the show to share those with you. Deborah.
Thanks, Denise. A Franklin County woman is doing everything she dreamed of and even more. Melissa West shares her journey with us. Melissa West has played the handbells at her church for nearly 20 years.
When we first get the new music, it's challenging, but then it's so much fun because I grew up playing a clarinet and I appreciate music. I love being able to involve the congregation in praising the Lord as we're playing it.
At times it was a struggle. Doctors diagnosed Melissa with epilepsy.
She was diagnosed in 2003. And she was diagnosed with localization-related epilepsy, meaning that it arises in a specific area before it becomes widespread across the brain.
Initially, Melissa had a seizure every month.
When I first started having them, I'd walk around and touch things. I would be singing little bits of things. My grandmother said, "Sometimes I know you were practicing for choir, even though you weren't actually in choir practice."
To control the seizures, doctors laid out a treatment plan.
She started on anti-seizure medication, and she was then escalated to multiple anti-seizure drugs to be taken at the same time. And unfortunately, despite use of multiple medications, her seizures still weren't under control and they became more frequent.
The seizures increased to 6 or 7 times a month. Doctors recommended vagal nerve stimulation, or VNS.
The vagal nerve stimulator is a type of neurostimulation device utilized to treat epilepsy. It basically stimulates the nerve in the neck called the vagus nerve, which is one of the cranial nerves. So we can stimulate that nerve and basically find pathways into the brain, so indirectly stimulating the brain to try and decrease the seizures.
The neuroscience team worked closely together to make sure the correct areas were targeted.
When they go to the OR and those electrodes are implanted, we usually are there in the OR. We're monitoring the patient while Dr. Sather is implanting the electrodes. We're looking for different types of activity that tends to indicate that the seizures could arise from a specific location.
When they put in the VNS implant, it helped control them some, but it didn't stop them. That brought it back down to the 1 a month.
After further studies, doctors suggested surgery to stop Melissa's seizures for good.
And what they determined was that the seizures were not bilateral, but actually all coming from the left temporal cortex or the anterior temporal cortex. So then at that particular time, she was considered to be a surgical candidate and referred to Dr. Sather for resection of that seizure focus.
A temporal lobectomy involves an incision on either the right or the left side, depending on the side of the seizures, exposing that area of the temporal lobe and then removing the tissue that is abnormal, in this case the hippocampus, along with the abnormal connections, the areas of the brain that are determined to be abnormal.
He was hoping that was going to stop all the seizures and it would not have any more. He did tell me there were side effects that you could get, but he said, knowing you and your orneriness, you're not going to have that problem.
The procedure was a success.
She's no longer had any additional seizures, and she's also been able to wean off of her medications except for one. So at the time of surgery, she was on 4 anti-seizure medications to try to help control her seizures. Now she's on 1 medication.
Melissa has been seizure-free for nearly 8 years. She is doing everything she's always wanted to do, and even more, like attending Wilson College.
I am a junior. My major is psychology. I want to help other people, both parents and those who are going through the disability itself. I want to, with the life experience that I've had, show them that they can do things. You know, just because somebody says you can't doesn't mean you can't. I'm walking proof.
Walking proof that anything is possible for Melissa.
It's obviously very rewarding to have a patient have such a debilitating condition and then be able to, help them and have such a dramatic change in their quality of life.
It's a whole new world. So many things that people said you could never do. It would never be possible. And I have. I'm doing all kinds of things.
Once being diagnosed with epilepsy, Melissa was not able to drive a car. After the surgery, she was able to get her license, and she's been driving for 5 years. Another huge accomplishment for Melissa. Now joining us is Dr. Tiffany Fisher, Chief of Epilepsy at Penn State Health, and also Melissa's doctor. Thanks for being with us. It sounds like we're having maybe having a hard time hearing you, okay. Dr. Fisher?
Yes, ma'am.
Okay.
Thank you for having me.
Okay, great. Why don't you talk to us about some of the signs and symptoms? We know that Melissa's doing great right now.
Yes, she is. So interesting, epilepsy may present with various signs and symptoms. Many people typically consider seizures to be convulsions only. However, there are other indicators, and these include jerking of the arms or legs, stiffening of the body, loss of consciousness, unexplained incontinence or loss of bowel or bladder. There can be sudden falling without reason, confusion, time lapse, or what we consider blackouts, staring and unresponsiveness. There are a variety of symptoms that occur that are indicative of seizures.
So if you do have some of these symptoms, how do you actually diagnose it?
So when a patient presents following a seizure and has been stabilized, there are multiple tests performed, including a neurological exam, blood work to evaluate for infection and metabolic derangements, and possibly a urine sample. Neurologists are specifically interested in an electroencephalogram or EEG, an MRI of the brain. The EEG is used to evaluate the electrical activity of the brain and assess for abnormal patterns that suggest you have a seizure disorder, while we use the MRI to examine the brain architecture for structural abnormalities that may indicate an underlying cause or etiology of your seizures.
Now we know that Melissa did have surgery. What are some non-surgical treatments for epilepsy?
So most patients with epilepsy become seizure-free with non-surgical treatments. The most often used therapies are medications that have various mechanisms of action. We typically prescribe an anti-seizure drug that best treats the patient's type of epilepsy, with consideration given to the patient's age, their gender, and potential interactions with other medications. We initiate the medication at a low dose and then gradually increase it until the seizures are well controlled. The ketogenic diet is another non-surgical treatment where high fat with low carbohydrates are eaten to improve seizure control. This diet is commonly used in children or often after failing several medications and monitored by a dietitian.
And talk about how treatments have evolved over the years.
So for many years, we've relied heavily on medications alone to treat patients. However, there's been a multitude of new anti-seizure drugs developed since the mid-1990s. These have different mechanisms of action and typically lower side effect profiles. Research into understanding how these drugs work has offered patients with epilepsy various medication options to treat their seizures. There has also been advancement in both surgical techniques and development of new therapies. We can provide our patients with less invasive techniques, such as MRI-guided laser ablation, targeted to where the seizures arise, or utilizing specialized electrodes to better pinpoint the seizure focus for surgical removal of the tissue. Lastly, neuromodulatory therapies, such as those mentioned, the vagal nerve stimulator, responsive neurostimulator, and deep brain stimulator present advanced treatment options in cases where surgery may not be a viable choice.
Yeah, certainly some great advancements. Dr. Fisher, thank you, but we want you to stick around because we're going to talk to you a little bit later in the show. Now, for more information about Penn State Health, or if you would like to schedule an appointment, call 866-560-7138 or visit online at pennstatehealth.org. Now, let's check in with Denise McCracken to get some answers to some of the viewer questions you've received. Denise.
Thanks, Deborah. Well, here to answer those questions is Dr. Bhavin Shah, epileptologist at Penn State Health. Thank you so much for joining us tonight, doctor.
Thank you. My pleasure.
Now, our first viewer question is, what should you do to help someone if you do witness someone having a seizure?
Excellent question. So I'll answer this in two ways: what you should do and what you should not. When a person is having a seizure, ease them down to the floor, lay them on the one side. Make sure if they are wearing anything tight around their neck, loosen it out. Time the seizure. If the seizure goes on for longer than 5 minutes, call 911. Few things that you should not do. Definitely do not restrain patients and their movements. Do not try to give CPR. Don't try to put anything in their mouth, such as with your fingers or anything. And do not feed them any water, any juice, or anything until they are back to their baseline.
Those are really good tips. Now, this next viewer has a question many people ask. How long does a seizure typically last, and when should you go to the emergency room?
Great question. The seizure timing is variable. It could last from about few seconds to few minutes. If your seizures go above 5 minutes, that should be your cue to go to emergency room. Along with other indications are if you have multiple cluster of seizures, such as if you have more than 2 or 3 seizures, they are shorter in duration, that would be one indication. Another, if they have difficulty breathing, if they are pregnant, if this is a first-time seizure, or if the seizure happened under the water. Those should be your cue to take the patient to emergency room.
Dr. Shah, thank you so much.
Thank you.
And if you have questions, you can join the live web chat right now. Go to abc27.com/brainstorm. And we'll check back in with Dr. Shah a little bit later in the show. Stay with us. We'll be right back.
I am a firm believer that nursing is a team sport.
At Penn State Health, we know that the hearts and minds of many together can make the most impact.
From the second I interviewed, I knew it was going to be the right fit for me.
It's just a great place to work.
As we redefine healthcare, it's time to reimagine your career.
Looking for people that are innovative and looking for people that are solution-focused and inquisitive and that challenge the status quo.
This is Penn State Health. Ready to join us?
You're watching Brainstorm on ABC 27, sponsored by Penn State Health.
Welcome back. A Cumberland County man never stopped doing the things he loves, no matter what anyone says. Chris Allmiller shares his journey with us. Chris Allmiller is a new dad. His daughter Zoe is 4 months old.
She's starting to smile back and giggle and grab and starting to do all the fun stuff that babies do.
Chris is living and loving life, accomplishing more things than he ever imagined after being diagnosed with epilepsy at age 16.
I was staying at a teammate's house because we were going to drive to Virginia the next day, and I woke up in the ambulance. They said I had a seizure and it would lead to visits to doctors, visits to all kinds of specialists, and I had no idea the future I was going to be in for.
He was diagnosed with localization-related epilepsy, meaning that it arises from one place. His specific place or foci was from the left frontal, so the frontal cortex for him.
I was having 3 or 4 a month, so about 1 a week. And then I would have the seizure, and I would fall asleep for about 5 or 6 hours once I got home, and I would wake up and be in a bad mood for the rest of the day because I had a seizure.
Part of the frustration was due to the fact that Chris kept missing the window to get a driver's license.
If you are 6 months free of having a seizure, you can apply to get your driver's license back. And that's always how I saw it.
To control the number of seizures, doctors recommended vagal nerve stimulation, or VNS.
The vagal nerve stimulator is one of the neurostimulation devices that we have for the treatment of epilepsy. It's the least invasive surgery that we have for the treatment of epilepsy, and the least invasive type of neurostimulator that we have for the treatment of epilepsy.
Chris saw a reduction in the number of seizures.
It was from 3 or 4 a month or 1 a week down to 2 or 3 a month, or at best every other week.
He had some improvement in his seizures, but not enough really to improve his quality of life significantly, that he wanted to have the discussion about what further options are available at this point.
Doctors suggested another device called the NeuroPace Responsive Neurostimulator, or RNS, with hopes of reducing the number of seizures even more.
We call it the NeuroPace. It's sort of a pacemaker for the brain.
This is directly on the brain. There's 4 electrodes that are directly laying on the brain right here. And then there's a battery that lays on top of them.
It uses tiny wires, but those wires are specifically threaded and implanted to the site where seizure onset occurs. So for Chris, it would be his left frontal lobe.
When there's an area of abnormality that sends out an electrical impulse consistent with seizures, the device can send back an impulse to stop or abort the seizures.
The stimulator is doing its job.
It's now down to 1 or 2 a month, or 1 every other week, or I've actually gone months without having a seizure. So it's been much more beneficial than anything I've done before.
He's got a very positive outlook, and he's done really, really well with his seizure reduction, so he's doing very well.
Well enough to embrace life with a smile.
Today I feel great. Married, baby. I never gave up on playing baseball, never gave up on any intramural sports. I'm back to bowling now, golfing, swimming, anything.
As far as driving a car, Chris hasn't been able to do that, but he says at this point in his life, it really doesn't matter. He's quite happy with where he's at. And joining us right now is Dr. Michael Sather, Surgical Director at the Epilepsy Center at Penn State Health. Thanks for being with us.
Thanks for having me.
You all work so closely together to treat both Melissa and Chris. Talk to us about this team collaboration that really benefits patients.
Yeah, so this team concept is so important in the treatment of epilepsy because epilepsy care is very multidisciplinary. And really working together is what allows us to maximize the outcomes for our patients. And this team is called the Epilepsy Center. So it's the group of individuals that I work with. We're all focused on the treatment of epilepsy, and that's their specialty. And as a group, we meet twice a month in patient management conference. And so we'll chat about patients who have difficult to control seizures. So patients that aren't responding to medications, and we'll review all their data, come up with some options on really what we think is most beneficial for them. And then we present that to the patients. And so really they get the whole thoughts from all the group to kind of make a decision from.
Sure. And there really have been so many advancements in surgery to treat epilepsy. What are some other surgical options?
Oh, sure. There's been a whole host of advancements over the last 10 years. And it's really not just in the surgeries and the techniques, but it's in some of the equipment we use as well. So for instance, we're using now robotic technology to implant the electrodes that we use in surgery. So with regards to the operations themselves, we have multiple forms of stimulation for epilepsy now. So it's not just the RNS that you saw that Chris had and the vagus nerve stimulator that we've discussed also, but deep brain stimulation as well. There's also a new minimally invasive procedure called stereotactic laser ablation, which utilizes a small laser fiber that we insert into an epileptic location in the brain to ablate an area to treat the seizure. So it's great because today we have so many options available to treat patients when their medications fail.
Why don't we talk about the outcomes? We know that Melissa and Chris, they're doing really well, but what are the outcomes like and what about follow-ups?
Yeah, so with the outcomes, on the average, the vagus nerve stimulator is associated with a 50 to 60% reduction in seizures, and with RNS and DBS, we generally see about a 70% reduction in seizures. Being devices, these things require adjustments by the neurologist and then eventually a surgery to change the battery. But as the data shows, these devices work really well. As you can see, it's worked well for Chris. With regards to the temporal lobectomy, on the other hand, this is a chance for seizure freedom, and the rate of that seizure freedom is around 70%. As you can see from Melissa, this is a great procedure, and most patients heal from this surgery in about 3 months.
And Dr. Sather, how does it make you feel that you and Dr. Fisher changed Chris and Melissa's lives?
Well, it obviously feels great to be able to have such an impact in someone's quality of life, and that's why we go into medicine. That's why we do the things we do. But it's really, it's not just Dr. Fisher and myself. It's the whole epilepsy team. We work with a big group, and I'm grateful to work with a lot of wonderful individuals that are all working to help take care of these patients and help me to do what I do.
Yeah, certainly wonderful outcomes. Dr. Sather, thanks so much.
Thank you very much.
And for more information about Penn State Health, or if you would like to schedule an appointment, call this number 866-560-7138 or visit online at pennstatehealth.org. Now let's check in with Denise for the answers to some more viewer questions. Denise.
Thanks, Deborah. Well, Dr. Shaw is back with us to answer a few more viewer questions. Our next viewer asks, what else can cause a seizure other than epilepsy?
Right, good question. Apart from epilepsy, other causes of seizure includes any type of alcohol or substance intoxication or their withdrawal, trauma, any types of medications, certain autoimmune conditions, brain tumors, strokes. Those are the other situations where you would have seizures.
The next viewer has a question about what Penn State Health offers. Penn State Health has an epilepsy monitoring unit. What happens there?
Yes, we do have an epilepsy monitoring unit. There are two basic purposes of getting patients into epilepsy monitoring unit. Either it could be diagnostic or it could be surgical pre-work. Diagnostic would include evaluating, that means localizing where the seizures are coming from, evaluating the effectiveness of seizure medications, and sometimes also evaluating if the seizures are non-epileptic or not. Surgical planning would include evaluating where the seizures are coming from and either do a surgical intervention such as resection or a neuromodulatory approach. Those two things would be the surgical part of EMU unit.
Dr. Shaw, you've given us a lot of great information tonight. Thank you so much for joining us.
Thank you.
And Dr. Shaw will answer your questions until 8. So if you have a question, you can join the live web chat right now. Go to abc27.com/brainstorm. Deborah, back to you.
Thanks, Denise. And back with us is Dr. Fisher, Chief of Epilepsy at Penn State Health. A lot of really good information tonight about treating seizures. Let's talk about research, though. Why is that so critical?
So research is vital in providing more effective treatments for our patients. Research from the bench side, such as examining seizure networks and utilization of seizure prediction models for therapy, all the way to the bedside with involvement in clinical trials for medications, novel therapies, or devices has aided in advancing treatment. Ultimately, research allows us to provide a standard of care to patients that is both comprehensive as well as innovative.
And let's also talk about treating the entire patient and not just the seizures, because we really do know how much this impacts their lives.
So we try our best to achieve a balance between seizure control and quality of life. This goal is definitely a fine line to walk, but we first like to know what is most important to the patient. That may be resuming a role such as returning to photography, being able to stay at home alone, traveling to a destination or on vacation, or even returning to work. Then we attempt to achieve a realistic goal while treating their seizures and mitigating side effects. We know that seizures impact the whole person as well as their caregivers. So careful consideration is always given to improving the quality of life while also improving their seizure control.
And what about the future? So many advancements, but I'm sure the future looks bright.
Absolutely. There are always new drugs in development, in addition to novel drug delivery mechanisms and amazing therapies. We can look forward to subthreshold stimulation, which is similar to the other devices mentioned, except that the stimulation is below a certain level. We can use MRI-guided ultrasound, which is a minimally invasive targeted surgical approach, or transcranial magnetic stimulation, where focused magnetic fields are applied to the areas of the brain where seizures occur. There are also efforts to look at the interplay of epilepsy and other neurological disorders, such as stroke, Alzheimer's disease, and traumatic brain injury. The future of epilepsy looks promising with continued efforts and research that not only improve seizure control, but also enhance patient care.
Okay, Dr. Fisher, thank you. Lots of really good information, and thank you for all that you do and everyone there at the center does.
Thank you.
And we also want to thank Melissa and Chris for sharing their stories and our viewers for sending in your questions. We send a special thanks to all of the healthcare employees who are working during this pandemic. If you would like more information, or if you would like to schedule an appointment with Penn State Health, this is the number to call, 866-560-7138. Once again, that number is 866-560-7138, or visit online at pennstatehealth.org. We want to thank you for watching tonight. We wish you good health.